Welcome, everyone, and thank you for joining us today for the latest webinar in the Donald Maloney, MD, Dialysis Leadership Medical Director webinar series. I'm Kelly Brooks, coordinator for the Forum of ESRD Networks, and I have a few housekeeping items to go over before we begin. First, please remain muted to minimize background noise and interruptions. You will have the opportunity to submit questions using the chat feature. You may submit questions at any time during the presentation, and we will answer them at the end of the webinar. Today's presentation is being recorded and will be posted to the forum website for future reference. A survey link to an evaluation form will be included in the chat and in a follow-up email you will receive after the webinar. We would very much appreciate your feedback. So let's get started. I'd like to introduce Dr. Landry, Forum President, who has some introductory remarks.
Thanks, Kelly, and good afternoon and good morning, I think, to everyone. It's a pleasure to have you all here today. For those who don't know, this is our fifth installment of 9 as part of the Donald Maloney Dialysis Leadership Medical Director Series. And I hope you enjoyed as much as I think you've all enjoyed the previous episodes. As you can see, we're kind of going through here over the next couple months to kind of complete this series. As Kelly mentioned, it'll be available to you at any time online, free access, and we really encourage you to please share it amongst yourselves and your friends. And if any feedback is very, very much appreciated, and certainly every bit as much as the appreciation we have for Don Maloney, who's been just a great partner and colleague for the forum for so many years. And next slide, please, Kelly. And as I was kind of just alluding to earlier, the fifth of our 9 talks today. But as you can see, in the coming weeks and a month or two, we'll also have some discussions regarding the QAPI process and how to utilize that to really improve patient care. Emergency management and disaster preparedness, a major feature for anybody who's going to be a medical director. And then we'll, of course, talk more about home dialysis and how that plays a role in value-based care models. And then we're going to kind of finish things off with this series with a great conversation, a great talk about what are best effective ways to actually round in a dialysis unit and provide the best care for your patients as well as your staff members. So again, we really encourage everyone to try to attend these if you can. Next slide, please, Kelly. And today, it's my great honor to introduce someone I'm proud to call a friend and colleague, Dr. Preethi Yerram. She is a professor of medicine in the Division of Nephrology at the University of Missouri-Columbia. She's also a staff nephrologist at the Harry S. Truman Veterans Administration Hospital. She's a transplant nephrologist as well, and is a member of ESRD Network 12's Medical Review Board, as well as currently serving as our chair for the Medical Advisory Council and soon to be our president-elect. I also would like to kind of throw in a plug as well, just to mention that she and just a couple other colleagues were really instrumental in putting together the recent annual dialysis conference that takes place every year in Missouri. I was fortunate enough to attend. And I just want to say that it's one of the best run conferences I've ever been to in terms of offering some great information for not just adult nephrology care, but also pediatric, clinical in all aspects, and something that I'd really recommend everyone keep their eye out for next year's meeting, okay? And next slide, please, Kelly. And so today, Preethi will be speaking to you. I guess she'll be pulling up her slides here in a second, but she'll be speaking to you with regards to how the ESRD networks function, how we work to help support the care of our patients and people who provide care to those patients in their communities, and how we address and deal with patient-provider conflict. So I can't think of a better person to give this talk. Dr. Yerram, thank you for being here.
Thanks so much, Dan. That was really kind, and thanks for the ADC plug. I appreciate that. Okay, so today's topic is something that's really important, and I'm sure many of you have dealt with conflict with a patient at some point in your career if you have worked with dialysis patients. So what I intend to do with this session is, I want to focus on kind of reframing the question that conflict is a result of, things that are kind of related to loss of control, maybe a system strain, patient distress, and kind of reframe our thinking process and also look at what we can do in terms of dealing with these issues, and also talk about how important it is to consider the ESRD networks as your partner in these conflict situations in dealing with grievances, and how early involvement of ESRD networks is going to be really helpful in these situations. All right, so we will start with what ESRD networks are. So these are 18 regional networks. These are CMS funded. They cover all US states and territories. The goal is to serve dialysis transplant facilities, patients, and providers in its region. As you can see here, we have more than 800,000 ESRD patients, and this includes patients on dialysis, transplanted patients. So this is a lot of patients, and there is a lot of oversight that these patients require in terms of like quality improvement and other things. So CMS has contracted these ESRD networks to look at the quality that's provided to these patients. So that's kind of their main role. This is a federally mandated role. And it's important to know that ESRD networks are not regulators. These are actually our friends. They want to help improve the quality that we provide to our patients, and also intervene early on and provide staff education, be a mediator. They could be a neutral party. And so they are going to be, helping us in delivering the best possible care for our patients. So with that, this is the map that shows all the ESRD networks. We have 18 networks that I mentioned, and the contracts are held by different organizations. And there is the next contract is actually pending, and we should be hearing who is going to get those contracts, I believe, any day now. And the forum is the organization where all the networks are a part of. And, I'm the president-elect now, and Dan is currently serving as the president. So we have the board of directors. Then we have the Executive Director Advisory Council, the Medical Advisory Council, the Kidney Patient Advisory Council, and the KPAC is a very, very unique part of this organization, and they do a ton of things. They do so much for advocacy. They are constantly publishing. They are putting information out there that is helpful for providers and patients. So we are very, very fortunate to be able to work with a very active and motivated and dedicated KPAC. So in this format, the goal is for the forum to assist the networks. So there are lots of council activities that are happening independently, the EDAC, MAC, and KPAC, but also we work together. We are communicating with CMS. We facilitate the flow of information between the forum and networks. And then we also establish relationship with other stakeholders. We have partnered with RPA, the Renal Healthcare Association, ASN, American Association of Kidney Patients, and right now we are currently working with the American Society of Pediatric Nephrology in trying to develop a toolkit for pediatric patients on dialysis. So, and we are always staying active. We have lots of toolkits that are available on the forum website, and as you can see up there, the core values are volunteerism. This is a volunteer-run organization. And we are very thankful for all the members that are dedicating their time to improve the quality of care, because that's the eventual goal, is to improve the quality of care we provide to our ESRD patients. All right, I mentioned a little bit of this already, but the main take-home point, if you get nothing else from this session today, is to know that the ESRD network is actually there to help you. And I can tell you from my own experience before I started getting involved with the networks that, there was always, and especially talking to the staff at a dialysis unit, and this would include our nurse managers, our administrator, there was always a negative connotation when it came to involving the network in anything related to the dialysis unit's activities, right? Because there is always this fear of okay, if the network gets involved, we are going to get cited or whatever it is. So there is that fear, and I think I realize that because I have been there. But it's important to know that the networks are not there to like make things bad for you or worse for you. So they have lots of resources. They can provide education and toolkits. And one of the things that I would be highlighting is the Decreasing Dialysis Patient Provider Toolkit that's freely available on the forum website and all the network websites. The networks can provide technical assistance where the staff can come to your facility. They can provide training, QI coaching, conflict reduction strategies, all of those. They are required to investigate grievances when a complaint is made, and that's a mandated job. Sorry, did somebody say something? Okay. And they are also involved in, keeping track of the quality metrics. And most importantly, they are there to be collaborative. They are not regulators. They are allies in quality improvement. And they can be neutral party, third party mediators when a grievance arises or you have a conflict situation that's happening in your dialysis unit. So with that background, I want to jump to the patient-provider conflict part of it. And so before we go there, I want to start off with a poll. So hopefully this will show up. Okay. How often, and you can just use your phone's camera to scan that QR code. And I think once you join, you won't have to do it with every question. And I think I have 2 or 3 more. So how often does patient-provider conflict come up in your dialysis unit? Daily, weekly, monthly, rarely, almost never. I'm going to give it a few seconds there. Okay. This is interesting. Okay, there's almost never. I did not think that would be something that people would pick. Okay. Okay. All right. So I think most of the people picked rarely. There are some that picked monthly, weekly, almost never. But basically, I think it's not a very common occurrence, it seems like, but there are some that would see it, from time to time. Okay, we'll move on. So why does conflict happen in dialysis settings, right? Because there are lots of factors. There are patient factors, there are system and staff factors. So in terms of patient factors, there is, the fundamental thing of a patient that starts dialysis is that they have a lot of fear of this new treatment, something that they haven't really experienced ever, or it's a very new thing, right? So there is a lot of fear associated with that and a loss of autonomy. Especially if you're going to a dialysis unit and you're letting somebody else, stick needles into you, and you're sitting there, your blood pressure is dropping, so you lose the control. So I think that puts a lot of stress on patients, and obviously there is a lot of grief associated with somebody transitioning to ESRD. And depression and anxiety kind of go along with that. There are other factors like cognitive impairment, dementia, substance use. Unmet social needs, these are a major contributor as well. Food insecurity, housing, transportation. There could also be health literacy challenges. People, certain patients may not understand what you're talking about. They don't know why you're asking them to do certain things. And this could include language barriers as well. And some patients just have mistrust of the healthcare system from previous experiences. On the system side, on the staff side, we all have dealt with this, especially as we went through the COVID era, right? So high patient to staff ratios, we know what that's like. Being super short staffed, and then you are still having to deal with extra patients and patients that are getting too sick. And so these are all, increasing the strain on the system as well as the staff, leading to staff burnout. It leads to depersonalization. And you kind of become numb emotionally as well, especially this has been described very well during the COVID times. There is communication breakdown across the care team. Somebody is busy, they have not been able to communicate as well. That can lead to some misunderstandings, and conflicts can come up because of that. cultural mismatch. There, again, this is important to kind of keep in mind because certain things that are normal for certain cultures may not be for others. So that can also lead to some conflict situations. And inconsistent enforcement of facility policies, inadequate training, and conflict de-escalation, because there is such a thing as training, right? So we are not all expected to deal with conflicts naturally, because that could be a learned skill, and we'll talk a little bit about in the next few slides how that could be something that could be developed. So if we let the conflict brew, what happens? What are the consequences of unresolved conflict? Obviously, patient safety risk. If there is conflict, if the patients don't feel like they want to deal with this on a day-to-day basis, or they have some sort of animosity, they are going to miss treatments, and you would label those patients as being non-adherent, and they may have delayed access to care. And these are all directly related to poor clinical outcomes. Obviously, staff could be burnt out because the same kind of animosity would also happen on the staff side. So they may not want to deal with a particular patient or like this, and over time they are not really enjoying the work. So that would lead to staff burnout. And regulatory exposure, obviously, these can escalate and lead to grievances. And then that could trigger network investigations, which is obviously not the ideal situation at all. And that is something that all dialysis facilities want to avoid. And then if you do get to the point of like this conflict escalation, involuntary discharge may be the unintended consequence, and that is associated with a lot of heavy ethical and regulatory burdens. So there is good reason for us to avoid these situations. And before we get to those strategies, I also want to take some time and talk about the social determinants of health and how they could be the root causes of conflict. So another question here, if you want to go back to your Slido, when a patient appears non-compliant, how often do you think the root cause is actually a social determinant? Almost always, often, sometimes, rarely. I'm not sure. Okay. I am actually... Okay, I was just going to say nobody picked rarely, and somebody just picked it. Okay. Okay. All right, I'll give it a couple more seconds. Okay, so it looks like majority of you think there is definitely a role for social determinants of health in having this conflict. 44% of you said almost always, and almost 50% of you said often or sometimes. Okay. So social determinants of health, again, these are things that are something that the patient is dealing with on a day-to-day basis. And it's important to keep in mind that, once the patient steps into the dialysis unit, they're not going to magically go away, right? They're part of the patient's, so it's important to recognize that these may be following the patient into the unit, and those may have bearing on what's going on in terms of the patient's behavior or other things that are coming up. And again, I mentioned this a little bit in the previous slide, but social determinants of health could be in any form: food insecurity, housing instability, transportation barriers, limited health literacy, somebody not being employed or underemployed, mental health and substance abuse, language barriers, or incarceration history. So it's really important, like when we are trying to deal with a patient that we think is, being disruptive, just ask yourself, is there something else that's leading to this behavior, be it non-adherence or disruptive behavior? For example, I put in something here. If Mr. Jones is skipping his phosphorus binders, is there a reason he's doing that? Can he afford to refill them, or is there another reason? And if a patient is not able to fill his binders because he can't, afford them, then obviously it's rooted in poverty, not like, he doesn't want to listen to you, he just can't get it. So start with empathy, not judgment. So this is really important to keep in mind, and lead with and give the benefit of doubt and just look at what could be driving this behavior. So what can your what team do? Know your patient population. We talked about this a little bit again. Know their socio-demographic factors, are there language barriers? The social determinant of health screenings can help. But you don't want to just stop at the screening. Once you find out that the patient may have certain barriers, it's important to make sure that you can offer them resources. Sometimes, obviously, we cannot fix all the issues, but at least try to provide what resources you have available or direct them to other organizations that may be able to help them. Build cultural awareness. This is really important, and I mentioned this already. Things that are acceptable in one culture may not be acceptable in different cultures. So it's important to know what the right thing to do is in a particular situations. And connecting to community resources again, the social workers do a great job with this already. And I know all your social workers that are on the call. God bless you. You do a wonderful job, and I know your job is not easy. Your plates are quite full. But I know our social workers that are constantly keeping up with the resources, food pantries, Meals on Wheels, pharmacy assistance programs. So there are certain organizations that also have these listed. For example, in Missouri, I think the Truman Hospital has a page on their website actually listing all the local resources. Missouri Kidney Program in Missouri has that available as well. So there may be several local organizations that may be helping out with this sort of thing. So moving on to some strategies to help with conflict management. So the first thing I want to address is self-awareness and triggers. And this is probably the most underused tool in conflict prevention. And this is kind of knowing yourself. And I'm not saying by any means, I'm not an expert at this, and this is something I'm working on. And as I was preparing this presentation, it also dawned on me that this is not something that is just useful to prevent conflict in a dialysis unit. I was like, wow, this may work with my 16-year-old son, right? So this is just, I think, helpful across the board in just your interactions with another human being. So this is some great information to have and some strategies to actually work on. So self-awareness is the foundation of conflict prevention. Why is that? Because, if you kind of can figure out how you react in a certain situation, how your actions, thoughts, and body language align with your professional standards, then you can catch yourself doing certain things that may not be ideal in a situation and then hold yourself back or respond in a different way. So the goal is to respond and not react. So it does help to kind of, think about what are your personality traits, understanding who you are, especially in a stressful environment. What are your personal values? What matters to you? What guides the decisions that you can be proud of? Keeping check of your emotions, understanding your feelings and how they drive your actions. If you notice that, if you feel stressed, you act in a certain way. And if you have an insight of that, you will have a better chance of being able to control that. Psychological needs, again, needs like control, esteem, belonging do drive behavior because, some people want to have the last word, and that may not necessarily be the right thing to do in a conflict situation, right? So again, having an insight of that sort of thing would be helpful. And being aware of automatic behaviors, good and bad, is key to growth. And obviously, we are all humans. We are not perfect. So if you think I have these XYZ that I want to improve on, but I also have this great trait, then you want to improve your useful beneficial traits and try to work on decreasing the traits that may not be helpful in these situations. So again, the triggers, patterns of situations, patients, or behaviors that consistently make you feel angry, stressed, or uncomfortable. So recognizing these triggers and kind of, being self-aware of your own traits, your values, your habits is going to really be key in dealing with conflict prevention. So another part of the triggers and also the self-awareness is recognizing the fight or flight mechanism. And I know in this day and age, there is a lot of mention of fight or flight with stress and everything. So, and this is something that I'm sure a lot of you are already aware of. The physiology is that it's a sympathetic nervous system response. And, a lot of times people say like back in the Stone Age, you were being chased by a lion and you're just like, holding for dear life and just running to save your life. So that is essentially the fight. And so you have two options. You either like run away from the lion or you try to fight it. Obviously, running away is probably the better option in that case. So it is a similar response, but obviously there is no lion to chase us in this day and age. But there are other stressors that can create the same kind of physiological response. So this is, where your stress hormones go up, your heart rate goes up, oxygen flows to the muscles, and you become tense, and you can see the flushed face. So the things you may see are listed on the right side. The pupils dilate, face can become red, you have like clenched jaw or fist, there's rapid heart rate, people are starting to pick up on their voice, or their pitch or volume increases, they're pacing or fidgeting or making threatening or irrational statements, because then you're really not processing your thoughts through your frontal lobe, and you're just kind of emotionally reacting. So this is really important, and because if you see this in a patient, obviously this is something that you have to get help, or like be ready to escape or something like that. But if you also see this happening in yourself, then it's time for you to kind of get yourself on a calmer note. So what are the de-escalation techniques that we can use to help in these situations? So Thompson's 5 universal truths of human interaction are really important to kind of go over, because these are things that every human wants, and it's not just the patient, right? It applies to each one of us. We all want to be treated with respect and dignity, right? So if we want to be treated that way, it's important that we treat the other person, be it a patient or anyone else, the same way. All people want to be asked rather than told. For example, just don't say, hey, sit down, I'm going to put this needle in, could you please, rather, and again, these are just manners that we have always taught our kids, we grew up learning. So these are just basic things. People want to be respected. And all the people want to know why they are being asked to do certain things, right? They just don't want to they don't like being told blanketly, for example, you have to do this, without being told why something is being asked of them. So it's important to explain the rationale. For example, we need you to sit still so I can get the needle in safely and get you on faster. If somebody is fidgeting, or like they're like pacing and they're saying, I want the needle in and I want to get started, obviously that's not going to work. So you explain why you're asking them to sit still, so you can do XYZ. And all people want options, not threats. You don't want somebody telling you do this or else you're going to be discharged from the dialysis unit. And obviously that creates the stress response and all the negative connotations that come with it. So in other words, you can say, okay, there are 2 ways we can handle this, and we can do this or this. It's that way you're giving the patient a choice. And it's always better, like we always do better, like as humans, when we feel like we have some control. So that's a really important strategy as well. And all people want a second chance, right? Avoid forever language. Yesterday's conflict is not today's encounter. So don't say, because you did this, this is it, or something like that, because people always, always change. We all want a second chance. And if you are in a conflict situation already, it is an active conflict situation, how do you de-escalate it? So it's important to take a breath, and literally this is just, 1 or 2 deep breaths is all you need before you can reset your nervous system. And there is a lot of evidence to show that this will activate your parasympathetic system, which is your vagus nerve, the calming side of your nervous system. But always make sure you're safe, right? Have a planned escape route, maintain 2 arm lengths from a patient, keep hands visible, because you don't want the patient to think that you are holding something in your hands if you, or turn your back. So be mindful of those things. And we talked about the signs of fight or flight response. So if you are seeing any of those signs, it's important to make sure that you have an escape route and you're able to get help. Stay at eye level, sit down if possible. And this is something that we've always been told, even in med school. Standing over a patient signals dominance, the opposite of de-escalation. So you want to sit down at their level. We don't want to just, have a big group and, going and talking to the patient, multiple people all at once. So we want to designate one speaker, because when you have simultaneous, conversations happening, it can cause chaos. It can create chaos. So one calm voice and everyone else steps back. You also want to reflect and restate. For example, tell me if I have this right. It tells you that you're listening to the patient, which is what the patients need. They don't want to be told, right? They want to know that you're listening, and set a limit, not a threat. You want to tell them that you want to help them, and yelling at staff is not okay. And can we find a way to fix this together? So these are some of the scripts that can be passed on, and people can be trained on, the staff at the dialysis units or in other situations as well. And one important thing, again, it's very important to take this home with you, because this is something that I have seen a lot of recently, because I think it's very common for us to want to say, I understand how you feel, but apparently, we don't like to hear that, because you are always like, how can you understand how I feel? My feelings are like much more worse than what you think or what you have experienced. So you cannot really tell a patient or tell anyone else that is going through an emotional turmoil that you understand how you feel, because obviously they are very at a different level. We don't know what their emotional state is. So and patients don't usually believe it when you say that. So, and it feels like it's dismissing the real suffering. So instead you say, that sounds really hard. So if there's another takeaway that I want you to have from this session, stop using I understand how you feel. Instead, just validate their feelings, saying that sounds really hard, and then go on to other things. And bring in support if needed, like be the charge nurse, social worker, facility manager. You want to bring them in before the conflict becomes physical, and that way they can help you in de-escalating the situation. So word on the communication strategies for conflict management. So two core communication skills are listen and assert. So one is active listening, and I've mentioned this already. Make eye contact, sit down at chair side. You can nod in agreement, use open-ended questions, and summarize what you have heard. It sounds like you're frustrated by so-and-so. Do not interrupt when they are trying to say something. Let them finish before you responding. And it's okay to pause, because a lot of times I think we are always in a rush. We are trying to complete the sentences for a patient or another person that we are talking to. So I think it's important to notice that urge, maybe if that is something that you do, and then pause before replying. Let the patient finish what they are saying. And then, like I said, avoid the phrase, I understand how you feel, and show it instead in action. And so that's one part. The other part is assertive statement. So you want to focus on the specific behavior, not the person. Validate the patient's feeling without agreeing with the behavior, and restate, show the benefit from their perspective. For example, Mrs. Smith, could you please sit still for just a moment? I can see you're eager to leave, and if we get this line in safely right now, you will be off the machine sooner. So you are validating the patient's feelings, but you're also telling them clearly that this is how it needs to happen for us to safely do the procedure and get you off of the machine. So these are some examples of common patient concerns and how to respond. So if the patient says, you never listen to me, it's not one size fits all. You could say something like, I'm sorry you feel I'm not listening. Please be specific about your concerns. I want to help with whatever I can, right? So that you're validating the patient's concerns, and you're offering help. So that way patient feels like you are actually trying to help them. And if a patient says there is an empty chair, why can't I go now? And I'm sure we have heard that before. And you can say something like, I understand the frustration. Our schedule keeps things running smoothly for everyone. Would you like to discuss a different time slot or something like that? In terms of like a patient safety concern, if a patient brings up, you didn't wash your hands like you're supposed to, and if this is something that truly a mistake, obviously you want to wash your hands, validate that. You're absolutely right. Thank you for the reminder. I won't let that happen again. And then, no, there is another example here. Nobody tells me anything. I already told the other nurse. And this is something that we have heard a lot again, even in the hospital setting, I hear this a lot. And this is a very common thing, because there are so many teams rounding, especially on the hospital side. So very much a common occurrence. And then in those situations, you can say, I'm sorry you had to repeat yourself. I'll make sure this gets to the right person and that we follow up with you. And the important thing is you make sure you follow up and you are getting the information to the right person, right? So because if you kind of let that go, then the patient gets more frustrated when the next person comes around and is asking the same question. All right, so the final section here is I want to focus a little bit on the tools, resources, and the conflict pathway, and this tells us why early intervention matters. So this is most of the material that I have covered in the presentation today is from the Decreasing Dialysis Patient Provider Conflict Project. It's an excellent resource. It's available on the forum website and also on many network websites, I believe. But what is the Decreasing Dialysis Patient Provider Conflict Project? This was an effort that was coordinated on a national basis by the ESRD community back in 2003 to provide resources to understand, educate, and cope with conflict in dialysis unit. So as a result of this task force that was established, we now have a DPC provider manual. There was a second edition that was published in 2008. There was an addendum to 2022. There are some revised modules that have been added in 2024. So these are really neat modules that actually help with staff training. So there's role play scripts and everything. So it's a very good resource. I strongly urge all of you to take a look, and I have some links at the end. The goals of DPC are to have safe dialysis facilities, increase awareness of conflict and improve skills to decrease conflict, improve staff-patient relationship, and create common language to describe conflict, right? Because what non-adherence means in one unit may be different from other units, or what one person is saying, may be interpreted differently in a different setting. So the DPC has also done a great job of standardizing some of the terminology. So, and again, I did not put all the definitions in there, but these are all available in the toolkit, in the manual. So these are some of the terms that are listed, and they have standardized definitions. So we know when somebody is using the word non-adherence or a verbal abuse, that it means the same across all situations. So this helps standardize, what we are talking about, and also can help with research and other reporting requirements. Okay, so the DPC conflict pathway is one of the things that is available in the manual. And this is kind of a stepwise response. So staff level resolution. So when there is like early signs of a conflict, the first response is done by the direct care team. We talked about active listening, de-escalation, assertive communication, and document the issue, because that is really, really important. As things are going to escalate, if it does end up going to the network, or be filed as a grievance, then the network and the state agency or CMS can come back to you and audit. So it's important to make sure that you're documenting the issue very carefully. And obviously, our goal is to de-escalate it and also make sure that the patient is taken care of. So we definitely try and avoid this going to 4 or 5, stage 4 or 5. The second step is if the conflict cannot be resolved with the direct care team, then it can go to the charge nurse or the facility manager, who will then investigate, involve social work if needed, and communicate the resolution plan to the patient. And the next step up will be the medical director. If the medical and clinical issues remain unresolved at the nursing level, then the medical director will review the patient care plan, conduct a formal meeting, and again, documenting everything is key. So obviously, if 1, 2, and 3 do not work, then the next step is, ESRD network, patient files a grievance, or facility requests assistance, network investigates, mediates, and supports the resolution, not as regulator, but as a partner. And finally, when it does get to the CMS or state agency, the conditions for coverage violation or unresolved network referral is what would trigger this. This is very rare and is usually preventable with earlier intervention. And you don't, again, if you feel like even at stage 2 and 3, maybe 1 is probably too early to involve the network, but as you're going through these conflict escalations, if you feel like involving the network, or like just asking them for some help or ideas, could be helpful to prevent this going into the stage 4 or 5. So early, call to the network is not going to hurt. Like I said, there was this concern that involving the network would mean a sure like citation, but that's not the case. The network is not there to make trouble for you. They are there to help you and guide you through, a conflict resolution, because that's the best case scenario for everyone involved. And this is a poster that's available in the DPC manual, and they have this mnemonic conflict, and it stands for create a calm environment. So when you are dealing with a conflict, it's important to try to de-escalate, create a calm environment, take deep breaths, as we talked about. Open yourself to understanding others, take a non-judgmental approach, focus on the issue, look for solutions, implement agreement, continue to communicate, and take another look. And there's some explanation for this and a lot more detail in the manual. And again, I'm not going to go over this, but this is the conflict pathway that is available, and it shows like different pathways in terms of what you're dealing with. If there is risk to the patient, risk to facility, or risk to others, and how would you proceed? All right, time for another question. When is the ESRD network usually contacted in conflict situations at your facility? Early, when patterns or concerns first emerge, after repeated attempts fail, only after a formal patient grievance is filed, or we are not sure when to involve the network. I'll give a few seconds here. Is the poll not working? Not sure. Okay. I see some answers now. Okay, so I think more than half of the responders said after repeated attempts fail. There is a small percentage that said they are not sure when to involve the network. So hopefully with this session today, you have some idea, or you have a better idea of like when to engage the network. And then 23% about said early when patterns or concerns first emerge, so early intervention. So again, there's no right or wrong answer here, but early contacting the network is going to be helpful, because you can prevent escalation, and you are making the ESRD network a partner in dealing with this situation, and they can help you. So definitely, I think ideally you would involve the network early on, but obviously after repeated attempts fail is when I think most of the facilities would engage the network. And only after a formal patient grievances file is too late. We want to prevent that situation. So definitely we want to engage the network much earlier than that. All right. I want to spend a few minutes on the second chance program for IV involuntary discharge patients. So this is something that was tried out. I think the IPRO network of New York was one of the networks that started this. So this came out of the report in 2002 that the ESRD network reported there were 404 involuntary discharges. So these events are something that we never want to happen, but these are the patients that are being discharged from a dialysis unit for whatever reason, for disruptive behavior or other abuse, threats, or other things. And then suddenly these patients do not have a place to do dialysis. So they are most of the time like going to an emergency room and trying to get their dialysis as needed. And several of these patients end up dying because they don't have timely access to dialysis. The 2019 summary reported 10,067 access to care events, although they did not like tease out the number of IVDs. But basically, these are the events that we want to avoid. So what the network did was actually they looked at the patients that were being discharged involuntarily, and they were trying to place these patients in dialysis units after making a contract with them. So what they did was like I think there were different iterations of the program that were eventually kind of trialed out in different places. I think one program watched the patient dialyze in the inpatient setting, in a hospital setting, and if their behavior was well documented, they did not have any issues, they went on to be placed in another outpatient dialysis unit after being told that you have to maintain good behavior for 30 days, and it is up to the discretion of the outpatient unit whether to accept you after the 30 days or not. And the dialysis unit would not be on the hook to accept the patient. So they are not really expected to keep the patient if they did not want to keep the patient. So there were different variations of the program that were done in different parts of the country. There was a paper that was actually published based on this, and they were able to, I think, prevent 65% of the patients in that one study from actually not having a dialysis unit. They were able to rehome the patient, so to speak, into an outpatient dialysis unit. And it is important to keep in mind that involuntary discharges should be like a never occurrence, because CMS interpretive guidance for IVDs is very clear. They do say that this should be a very rare event, and it should be preceded by demonstrated effort on the part of the interdisciplinary team to address the problem in a mutually beneficial way. So as I said, we want all those interactions and the efforts that were taking place to be documented in a clear manner. Patients should not be discharged for shortened or mistreatments, and this is something that you do hear from time to time, that a patient was discharged for non-compliance or not showing up for treatments, but this is not a sanctioned reason for involuntary discharge unless this behavior has a significant adverse effect on other patients' treatment schedules. And there is more language in that if you want to look at it in more detail, but that's kind of the gist of it. And patients should not also be discharged for failure to reach facility set goals for clinical outcomes. We know these are all important for payments and such, but that should not be a reason for a patient to be discharged. So these are some of the DPC, the decreasing dialysis patient provider conflict resources that are available to you. These are free from your ESRD network. As I mentioned, the manual, the second edition, there is an addendum, the revised modules. These are very helpful training modules for the staff. It teaches you communication skills, and there are actually nice pre-written scripts that you can use. There is also a printable pocket guide, building bridges poster, and the conflict pathway that I showed you earlier. So the key takeaways from the session is that, I want you to remember that ESRD networks are partners, not regulators. Reach out early. They have free tools, training, and mediation support. Know your triggers. When there is a conflict, knowing yourself is going to help you be in better control of how you respond rather than react. Self-awareness is a clinical skill, so practice it like you would practice any other. Communication prevents and resolves conflict, so active listening and assertive statements are two of the most powerful tools in your unit. Social determinants of health drive more conflict than difficult personalities, as we discussed. So start with curiosity, not judgment. De-escalation is a team sport, so one designated calm voice should be used. Be safe. Do not make any threats. Just give options and show respect, because that way the patient will feel like they are in control, because it is really hard for somebody to go on dialysis, and it's a hard thing to cope with loss of autonomy and dealing with everything that's happening. Use the conflict pathway. Don't wait until it becomes a grievance. Intervene early, document thoroughly, and follow up. All right, so final poll. After today's session, what is one thing you're most likely to do differently in a patient conflict situation? Pause and regulate yourself first. Explore social determinants of health before labeling behavior. Use assertive language more intentionally. Reach out to your ESRD network sooner. Okay, is it working or no? I don't see any answers. Okay. Okay. So I do see almost 30% of them wanting to reach the ESRD network sooner, pause and regulate myself first, social determinants of health. Yeah, those are all great things to think about. Okay, so with that, I think I can take some questions and I'm happy to discuss anything further. Do we have anything in chat? Let me look.
We don't have anything in chat right now, Preethi.
Okay.
Kim
So I
says
see.
do not take her off our census yet. She said this is the first time she's ran outpatient is today, Wilma.
Oh, okay.
So leave her.
Oh, I guess that wasn't the question.
No.
At least not for you.
Okay. So I think I see D on the call. I know with one of the polls, I was asking about when would you reach out to the network, and I think most of them would reach when repeated attempts fail. So, Dee, can you, if you don't mind, make a comment on how do you see these pan out? Like, do most of the facilities call you after repeated attempts fail, or like when almost a grievance is ready to be filed, or are there, do they reach out very early on? And what do you recommend from your perspective?
Sure, I'd be happy to comment. Thank you, Dr. Yerram. This was a wonderful presentation. I'm messaging my patient services director too. We're both on here. It's really, really good information, and it's thank you for supporting the network work. We always, from the Network 11 perspective, I'll just say I'm the executive director at Network 11, and we've had a long-standing approach that we want to hear from facilities early in the process. Just like you were saying, the earlier you reach out, the more we want to partner with you to help do what's best for your staff and also for your patients. So we encourage that. Sometimes we do get calls after several attempts have been made, but we always want to hear from facilities early. So I second that wholeheartedly.
Perfect. Thank you. Okay. I think there's a question I see.
Yeah, I think
And yeah, I
I
think
have a
Lisa said the
patient
same
that
thing
wants
earlier,
to
the
have a
better.
breakdown on how much everything will cost prior to going to home hemo. I notice this person feels very out of control and angry with his own body not being healthy. His family supports him and being difficult to work with, and I have noticed it is detrimental to his health. Do you have any suggestions?
So, so is he not able to afford the medications, or is it just even dialysis treatment with what it's going to cost?
It's a good question, right?
Mhm.
I'm a little unclear too. It sounds like there's, things here that could be discussed in terms of, social drivers of health, right? And what are factors going on if there's, a person's concerned about what's going to cost for their care. I mean, that's something that I think oftentimes we don't always fully appreciate.
Yeah. And I think she said he fights me with everything and he has private insurance.
Uh,
Um, yeah, so I think, have, and are you a social worker? Is that, just want to ask what your role is. Cobra premiums. Okay. 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 Because I was gonna say maybe the social worker can help, but you are
Apparently
the
the answer
social
is
worker.
yes. Yes, exactly. So
So I can say, for example, in Missouri, where I am, we have the Missouri Kidney Program. That is really a great resource. We usually refer patients to them because they are excellent with all the insurance questions. So if you do have a state program like that, even I think, something like claim or the whatever you call it now, the SHIP program, I think the state health insurance program, they can counsel patients or provide information on like various insurance questions, be it Medicare, Medicare Advantage, or other things. So if you have something like that in your state, I would recommend that you possibly consider referring to that patient to them. They can provide more information for sure. I mean, even if you do not have a state kidney program, because there are very few states that do, I think the state health insurance program, they do have certified, I think, Medicare counselors, and they have a lot more information about all these insurance costs and all that. And I think I see another question. Somebody, if a patient refused to transfer involuntary after all the steps were done. I don't think I have run into that situation. I mean, at that point, if somebody has been, and they are, is that like considered trespassing at that point? I'm not sure. What was the situation in that particular, with that particular patient? Mara, can you maybe expand on that patient's particular situation? Okay. How can we access the cultural humility training? I believe it's part of the network, and I don't know how updated the networks keep their websites, but again, I'm gonna call out to Dee and see, Dee, do you know if your network keeps this updated? Like, are the links like functional or?
I can try to track that down and then we can get it to Kelly somehow
Okay.
to be distributed. Would that work?
Yeah, that would be perfect.
Okay.
Sounds good. So Regina, I think once we have that link, we Kelly can email that out to you or to the group, whatever works best.
Right. You got to thank you there too. So, no, what a wonderful talk today, Dr. Yerram. Thank you so much for this. I think it is a great reminder too, right, that we all kind of have to walk in, step into what we do every day with some humility, and know that sometimes when things don't click, it's okay to ask for help, and that's exactly what the networks are here for. And I think I don't think you could have explained it any better than that too in your talk today. So thank you. Um, but I think what we'll do right now is I'm going to hand things over to Kelly Brooks just to give a couple last final words. And otherwise, I want to say thank you again for everyone being here today. It was a great audience, great questions, and we look forward to seeing you all back for our next talk.
Thank you very much.
Yes. Thank you both, Dr. Yerram and Dr. Landry. That was a wonderful presentation, and I learned so much myself. I hope everybody can see my screen. I've put a link to the feedback survey in the chat, and you'll also receive it in a follow-up email. We welcome your comments and any suggestions you may have for future webinars. You may not know this, but the Forum is a volunteer-led nonprofit organization with limited financial resources. So if you enjoyed this webinar and would like to see more content from the Forum, please consider making a contribution to our organization. Lastly, if you're not following us on social media, please do. You can help us spread the word about all the Forum has to offer. Thank you once again for joining us today, and we hope you have a great day.
Thank you. Bye-bye.
Bye, everybody.